dance from both sides. We're going to be speaking about COPD year in review. I'll try and summarize for you what I thought were important topics to share with our colleagues about COPD, the most important publications that are relevant to our daily practice. Let's start with speaking about the reason for COPD, smoking. Have you heard about the prevalence of COPD, prevalence of smoking cessation and prevalence of smoking in the US and its decline? I didn't know that there was a significant decline in smoking prevalence in the US, as much as dropping from 42 to 12%. And this graph nicely shows from 1955 up to 2020, how much prevalence of smoking drop happened in the USA. And if we draw a line to expect when is the smoking prevalence gonna reach zero, it's gonna be 30 years roughly from now, if they continue on the same level. But have you asked yourself why that is? And what were the drivers? Professor Nasser Bahbahani yesterday over dinner was telling us about the most important factors to reduce smoking prevalence. And he touched on one of the things that I will share with you, and that is price. It was found that every 10% increase in the price of cigarette results in about 5% decrease in prevalence of smoking. And this is a very nice demonstration of how that is. You see in the blue graph how when the price goes up, the prevalence of smoking in USA was coming down. Other factors that you might be aware of is to control the advertisement for smoking and to ban smoking in governmental building or work-related offices. Unfortunately, it seems like the smoking effect does not affect all of us equivalently. It seems that there are certain categories of patient population that get more negative impact from smoking than others. The poor, less educated people, people with other comorbid conditions, especially addictive disorders, or certain ethnic background. And let's go over some of the literature that was published in the last year or so. This is what people are talking about and using the terminology of disparity. Disparity, if you look on the meaning of disparity, I had to look this up. Why are we using disparity instead of inequality? Disparity is when things are not similar, but you think this is not fair. So it seems like there are factors that are related to individual, for example, depending on our genetic makeup, factors that we cannot modify, or factors that we can modify, such as smoking, what we eat. Factors that are related to our environment, indoor pollution, outdoor pollution, our housing, our neighborhood. It seems that a lot of advocates are advocating against the use of spirometry as the sole tool to diagnose COPD. And you might ask yourself why that is. Because not everybody has the ability to have access to spirometry. We don't appreciate that maybe in a third world country or a country like UAE, but the access to spirometry is not as easy in certain countries. The cost of the test might be considered to be high. Having the allied healthcare worker who can perform the test properly and the physician to interpret the spirometry. And this has resulted, unfortunately, in COPD being underdiagnosed up to 90% in certain parts of the world, as this graph shows you. So what alternatives do we have to diagnose COPD? So researchers came up with questionnaires. One of them is called the CAPTCHA questionnaire, where you ask the patients about their quality of air, indoor or outdoor. You ask them about their breathing and whether their breathing is changed depending on their exposure, weather, season, and you ask them about any history of bronchitis events. And these questionnaires, in conjunction with more simpler tools such as peak expiratory flow rate tool were found to be a useful measure to predict chronic obstructive lung disease or even mortality. And I'll share some of the evidence with you. In one of the studies, where 4 domains were used, exposure being smoking history, symptoms being dyspnea using MRC scale, CT scan showing emphysema of more than 5%, or a spirometry showing a ratio less than 70, or FEV1 less than 80. It was found that joining exposure and symptoms was as good as using exposure and spirometry. The same odds ratio to predict mortality. Actually, having history of exposure to smoking and having symptoms of dyspnea, high MRC scale had a higher odds ratio of mortality, all-cause mortality compared to spirometry and smoking exposure. Now, COPD remains the 3rd leading cause of death. I'm not sure if these numbers are going to change. You can see on the dotted circles, on the solid circles, that non-communicable diseases continue to be the more responsible causes of death worldwide. COPD comes 3rd. Maybe with COVID, the communicable diseases now will be a higher rank. This is up to 2019. Disparity is the topic of this part of the talk. And by disparity, I mean, why is it that 80% of COPD death happens in low to middle income countries? We have to face this fact. This has resulted in researchers asking themselves, let's try something else. What can we try? So they used 3 questionnaires in 3 low-income countries. These countries were Nepal on the left, Peru, and Uganda. They used peak expiratory flow in conjunction with 3 questionnaires. The capture questionnaire that I mentioned earlier, the COLA questionnaire, and the lung function questionnaire, LFQ questionnaire. And they got a prevalence of COPD of 18 in Nepal, 2.7% in Peru and Uganda. And they assessed the area under the curve, and it was not too bad. It was 0.71 to 2.79 in Peru, using different combination of questionnaire and peak flow. The sensitivity was not great. It was as low as 38% in Nepal, up to 65% when using a different questionnaire with the peak expiratory flow. The lesson from this exercise is that screening instruments are feasible and reasonably sensitive, and your sensitivity goes higher, it seems like, and 95% of COPD patients who were diagnosed in this study, because they compared that to spirometry, unfortunately were previously undiagnosed. So this is the reason for experts suggesting that other tools besides spirometry should be looked at to diagnose COPD and reduce this disparity. Disparity is not only in access to testing. Disparity was also found in our genetic makeup. A study that assessed 3,000 subjects. It was a cardiac study. They followed those patients for 30 years, age 25 to 55, and they could identify 5 trajectories. And if you look at the red and the black trajectory, they called the red one the worsening lung health trajectory, and the black one persistently poor lung health. It seems like certain groups among us, they suffer from low FEV1 FVC ratio when you follow them for 30 years, as opposed to the other more healthy, preserved lung health. They call them preserved ideal lung health, good lung health, or impaired lung health. And this was also documented when they were doing serial CT scans for those young adults at age 55, and they found that the red and black trajectory actually had a higher prevalence of not only poor spirometry, but also emphysema. This was last year confirmed by another study, and they developed what is known now as the polygenic risk score. polygenic risk score has been associated with reduced lung growth on the right-hand side and reduced growth and early decline. So being in a poor country is a downside. Having certain genetic makeup is a downside. And even living in certain parts, if you live in Dubai, your risk of developing COPD is different than if you're living in a small town. How come? Well, this has been proven. This study that included 2,690 subjects for 20 years, according to the census from USA, they decided the neighborhood level depending on median household income, poverty level, and education. And they followed those patients in 4 quartiles, and Q4, unfortunately, depending on the neighborhood, the poor neighborhood was associated with a higher odd ratio risk of developing emphysema and COPD. So actually living in the city has a less risk for somebody to develop COPD. This was actually replicated by another study by Raifman only last year. And if you look at the orange and pink line, this represents people living in cities as compared to the green and light blue line, and those represent people living in rural area. And this is mortality at this age group. And you can see that living in a rural area is a negative thing. On the right-hand side, you can see the red line showing that people who are uninsured worldwide are less. So more insurance covering people. But unfortunately, the green line is going also down. And this represents people who cannot afford treatment. So not affording treatment is also increasing. The conclusion of this part of the year in review is to tell you that disparity in healthcare exists. In COPD, our genetic makeup can be part of this reason. Access to diagnostic tool can be part of reason. Where we're living a neighborhood can be part of this reason. And the last and the second part of my year in review is to talk about 2 other subjects. And that is, number 1, PE. I remember during our residency program 20 years ago, it has been always taught, we were always taught that whenever you get somebody with COPD exacerbation, make sure you look for PE, because PE is high prevalence, has high prevalence in COPD exacerbation, and it's underdiagnosed, as high as 20%. But a study was done last year and published. It's a Spanish study that has 18 centers, and they had 746 patients. They had a control arm, and they had a strategy of being aggressive pursuing diagnosis of PE by doing D-dimer and CTPA protocol. And their composite outcome was non-fatal symptomatic venothromboembolic disease, readmission with COPD, or 90 days mortality. And what did they found? They found actually that the prevalence of PE in COPD exacerbation among all patients was 5.1 in the intervention group and 3.3 in the usual care group. There was no difference with regard to side effects, and the overall prevalence of COPD, it seems like in this study, was much lower than what we were taught in the past. So I thought this is an important article to share with you, and the less aggressive pursuing less aggressive approach to detect PE in COPD exacerbation did not really affect their outcome. Last but not least, it is not wise not to speak about COVID during this time. COVID is still around, and this is a big study that was published in the UK. It had 8.3 million people in this study from 1,200 general practices in England. It recorded 14,400 COVID hospitalization, 5,900 deaths. And COPD, but not asthma, was associated with severe COVID. You probably know this by this time, and it was as high of a risk like having interstitial lung disease, idiopathic pulmonary fibrosis, or cancer. It was interesting to see that younger people had higher risk in this particular analysis than older people, but the researchers attributed this to younger people having high BMI. So COPD is a risk factor for COVID disease, for severe disease, and mortality. Last week, I was visiting the botanical garden in Berkeley, California, and I saw this plant, and it's called Japanese Ardisia, and this plant has been advocated by the Japanese to treat chronic cough as a mucolytic and for COPD. This was, for me, an eye-opener that we should always consider a new potential with regard to diagnostic tool or how to treat our patients. Thank you very much.